Good afternoon. The next 7 minutes or so, I'll be speaking about aponeurotic ptosis. Aponeurotic ptosis, also called involutional ptosis, has disinsertion of the levator, dehiscence of the levator, or degeneration. Just remember the 3 Ds as the possible mechanisms. Along with disinsertion or dehiscence, degeneration could be a component, or degeneration sometimes could be standalone without any dehiscence or disinsertion. Involution is typically age-related, but exactly similar ptosis can happen in patients who have had inflammation such as blepharocharesis, trauma, use of rigid gas permeable contact lenses, patients with chronic VKC, eye rubbing, allergic eye disease, mechanical causes such as recurrent chalazion. Anything can cause involution like aponeurotic ptosis. Typical features are that it is bilateral. As you see here, it is bilateral symmetrical. It could be bilateral asymmetrical. Left eye does have ptosis. When you lift the right eye does have ptosis. When you lift the left upper lid to its non-ptotic position, the right eye droops, that is herrings. Then it could be even unilateral. As you see here, this patient had a history of cataract surgery with a brittle suture of the superior rectus, following which he developed acute onset ptosis. Typical features are that there will be accompanying laxity of the eyelid skin, as you see here, high or faint eyelid crease, deep supratarsal sulcus. They invariably tend to have good levator action, 10, 12, 13, 14 millimeters. They have thin eyelid, and in a fair individual in a well-lit room, you can actually see the uveal reflex shining through the lid when the patient gently closes the lid. They also have canthal dehiscence. The lateral canthal angle, which is supposed to be sharp, gets blunted, and the ratio between the medial limbus to medial canthus to lateral limbus to lateral canthus, which is supposed to be 2:3 in Asian Indians, gets altered to perhaps 1:1. So lateral canthal dehiscence can be an accompanying feature which some patients want corrected. Like this patient has a narrowed lateral canthus to lateral limbus distance, and he also has difficulty in down gaze or climbing downstairs. That's because their palpebral fissure nearly closes when they look down. That's one of the complaints. Many of these patients come with difficulty in reading. When you see these patients, you have to look at what's the severity of the ptosis. Are there any complicating factors such as dry eye, or even for that matter, a giant fornix syndrome or a floppy eyelid that cannot be associated, that can complicate the surgery? Is surgery going to be safe for the patient, and what is the expected outcome? Critical information that you derive are just the same, but in addition you do the phenylephrine test to see if this patient would be a candidate for mullerectomy, and if so, then you could go ahead with it. Cosmetic indications overwhelm functional indications for surgery currently. Many patients who have functional indications are elderly and they don't prefer to undergo surgery. They somehow manage, but younger individuals are definitely keen on cosmesis. The surgeries that you perform, of course, mullerectomy, and then levator reattachment or plication. Very few patients undergo Fassler Severt procedure. That is a surgeon's choice. In levator reattachment, is classically for patients who have levator disinsertion, and we tend to do it in patients who have good levator action. We generally reinsert the levator to the middle or upper 1/3 of the tarsus, and sometimes we hang back if the levator action is even better. What I have found is that when the levator gets disinserted, it rolls back and gets attached to the orbital septum. This we find in a majority of patients like so. Now this is the edge of the levator that had rolled back and got attached to the septum. But this is actually the edge of the levator which is disinserted. You can see the aponeurotic component, and you can see the muscular component, and you can see fat infiltration in the muscular component. This is the zone of the Whitnell's ligament. So clearly this edge was not towards the tarsus. This edge was towards the septum. That happens because this edge got disinserted from the tarsus and it flipped back and got attached to the septum. This is a curious finding. Initially when I saw it, I thought, this could be just a freak case, but over a period of time, since I have been operating under an operating microscope with very high magnification, I've been able to recognize this in a majority of patients. And if you don't recognize this, you consider the knee where it bends as the real disinsertion, and you would attach this area to the tarsus, resulting in overcorrection. So if you identify this folded edge of levator, then you will be able to give a better result, I suppose. Now I'll show you a video clip which also shows the same. I'll skip these initial parts of the video. Yes, now dissection of the orbicularis, exposing the septum, then we are dissecting the tarsus. See, that's the edge of the rolled edge of the levator which is attached to the septum. I am disinserting it from the septum with very low RF. Sometimes it's difficult to dissect this layer with scissors. You can see the muscular components peeping through. That's the muscular component. That's the aponeurosis. That's the Whitnell's ligament. It's very clear the distinction between the aponeurosis and the muscular component. And then we simply reattach it. That's all the surgery. Where to reattach depends on the levator action and the length of the aponeurotic component that is visible. Sometimes in patients who have inflammation as the etiology, the aponeurotic component becomes extremely short. It becomes hardly 5 or 6 millimeter. That means that there is already natural resection because the aponeurosis has already undergone shrinkage. In such patients, if you reattach the aponeurosis to the middle of the tarsus and tie your sutures tight, then this patient is likely to have overcorrection because he has a natural resection effect already. So in such patients, we hang back the levator. It means the sutures are still taken through the upper 1/3 or 2/3 of middle of the tarsus, but the sutures are tied loose so that there is a hang back effect. With that, you are able to get much better results. These are some of the patients who have undergone levator reinsertion, and they do quite well. And more importantly, their functional component of not being able to see in down gaze also gets resolved because their cornea gets exposed in down gaze. Levator plication is specifically for patients who have levator dehiscence. The rule of thumb is 6 millimeter plication for every millimeter of ptosis. That is surgeon dependent. You can start with this particular thumb rule and keep on altering till you get or optimize your results. The initial steps of the surgery are the same. There is hardly any difference in the initial few steps. We have to identify that there is indeed dehiscence and not disinsertion before you plicate. You mark exactly the amount of plication that you want to have. I use these two dots for each arm of the suture to come out. Lamellar tarsal bite with 6-proline suture. Make sure that it has not gone full thickness to the tarsus. Then take a bite at the upper edge of the tarsus so that the plicated tissue lies at the upper edge and not comes over the surface of the tarsus. Then it may blunt the lid crease formation. Then go through the levator and come out at the intended site, which you see. That's the bite at the upper edge of the tarsus. Then you take one more bite and then come out at the intended point where you want to plicate. All three sutures are 6-proline. You can use a double arm suture as well if you're comfortable with it, or single arm suture, surgeon's choice. Similarly, medially and laterally. So all the three sutures are passed through the intended points and simply have to tie these sutures, giving the plication effect. This is one patient where the left eye has undergone plication, doing fairly well. Here is the left eye again having undergone plication. Right eye undergone plication. The lid crease also forms nicely with this technique. So in involutional ptosis, the most important aspect is to identify what has caused this, whether it is disinsertion, dehiscence, degeneration, or a combination of those. Identify the etiology first and try to address it. Mullerectomy is a very good choice, but I'm not talking about it because the time is 7 minutes. So mullerectomy is an extremely good procedure. I have only addressed levator reinsertion and plication. And of course, you can do levator resection in patients who have poor levator function, say 6, 7, 8 millimeter levator function, which is considered fair but not good enough for levator reattachment. In such patients, you can do advancement or small resection as well. Perfection is an unreasonable goal in ptosis surgery. This you have to explain till the patient understands. And if at all you have a surprise undercorrection or overcorrection, don't wait for the tincture of time, but go ahead and adjust it. I do all my adjustments under topical anesthesia. Patients generally don't have pain once, you simply can use topical anesthesia and adjust even in patients who are young. They cooperate fairly well. So we adjust early in about 15 to 20% of patients we need to do adjustment, and that we generally do in the first postoperative week itself. Thank you so much. Questions?
Thank you, sir.
Any questions?
Any questions from the audiences?
May I call Honavar? Okay.
Yeah.
Yeah, you can use adjustable sutures, but in that situation, you know, every patient has to be finally has to have a finalization of sutures. I don't use externalized adjustable sutures, but I tell my patients that you may be required to have an adjustment, especially, you know, when the length of the aponeurosis is so variable and the levator action is so variable, you may get surprise undercorrection or overcorrection. That may happen in 1 in 10 patients, but if the patients are informed that they may need adjustment, they are mentally prepared. The only point that the patient winces is when you take off the skin sutures. Beyond that, just use proparacaine drops, 3 or 4 drops, and we can actually pass the sutures again under topical anesthesia, and again the patient absolutely has no pain at all. Now the advantage of this is that you can know the exact position of the eyelid, whereas when you do your first surgery, you would have done it under frontal block. Despite using half a cc or 3/4 of cc of frontal block, there would be some mechanical effect of primary surgery, tissue edema for that matter, intraoperative, or little bleed that takes place. By 1 week, everything would have resolved. That's the best time to adjust. Yeah. Correlation I have found is shorter the length of the aponeurosis and better is the levator action, higher is the chance of overcorrection. And for some reason, patients who use a prosthetic eye where there is aponeurotic ptosis have a very high chance of overcorrection. I haven't found out the reason why.
So, how can we manage overcorrection in postoperative period, early and late?
Well, I mean, people advise stretching of the lid, massage, but I don't think that really works. Right? So, traction on the lid, all these are indirect attempts to loosen the sutures. If you have an overcorrection, it is best to open up and pass the suture at an appropriate height or with appropriate tightness in the immediate postoperative period, say within a week. That will give you more stable results than trying to give traction or massage or, you know, do whatever else.
To correct it, the surprises by 2 weeks, is it okay?
2 weeks would be the time when fibrosis would have already started.
As early as within a
Yeah,
week?
within a week, I think tissues are very fresh, and that I found that 5th or 6th day is the best time.
Thank you, sir.
Any other question?